So thank you, Arun. We'll go on to Dr. JITENDRA, who will be talking on clinical evaluation of strabismus and documentation.
Just a quick word on the previous one. We should also document keratometry because we should be
Yeah.
sure that it is axial myopia and not
Absolutely.
curvature myopia. So it
Absolutely.
is very important. And if there is esophoria, it is very easy to give progressive. That would help. Anyway, so coming back to my topic, at the outset, I would like to thank Dr. Chitra ma'am for giving the opportunity, and we will go straight to the topic because I think this is a very long topic. I will be speaking very quick. So, what is strabismus and workup of strabismus? Basically, what we do in this is we establish the presence and the type of strabismus, whether there is any presence of amblyopia or not, amount of deviation for the management part, and last but not the least is assessing binocular status of the patient. And this is very important in kids. We should be able to know what is the fixation pattern of the kid, and this is how we manage in pre-verbal children. Central study maintained fixation, and so we come to the motor evaluation. Cover test basically means not just part of cover test, but cover test encompasses almost all the tests. So cover test includes cover, uncover test, alternate cover test, prism cover test, simultaneous cover, prism cover test, corneal reflection test is inspection. So what information we get out of it is the type of deviation, whether it is coming from in to out, ESO, exo, hypo, hyper, unilateral, or whether it is alternate or not, the amount of deviation, the fixation pattern, presence of latent nystagmus, incompetent deviation, if any, depending on fixing right eye, fixing left eye, amount of deviation, presence of amblyopia, depending again on the fixation pattern and on the dominance of the eye, and any associated dissociated vertical or horizontal deviation. And for this we need, as Dr. Arun rightly said, we need a fixation target for near and distance. A torchlight is only for corneal reflection test. If we are planning to operate or planning to work up a strabismus patient, we need to control the accommodation, and that is only possible with accommodative target for near as well as for distance. We need an occluder and a prism bar to measure the amount of deviation. Corneal reflection test is a simple test. It is meant only to get a gross idea what is going on, because it is full of errors, like you may end up into diagnosing a pseudo-ESO, pseudo-exo. You may not, you may have a high angle kappa or a low angle kappa. And so, but basically you have a gross idea, which is the fixing eye. So that helps you go to the cover test, where basically you cover the seemingly fixating eye. It is very important to cover the fixating eye, because if you cover the non-fixing eye, it doesn't give you any information. So basically you cover the seemingly fixating eye, and the response of non-fixing eye is observed. If it moves from out to in, it is exo. If it moves from in to out, it is ESO. If it comes from up to down, it is hypo. If it comes from up to down, it is hyper, and if it comes from down to up, it is hypo. And then this is how you notify them. If there is intermittent exotropia, you notify them at X bracket T, and likewise if there is constant exo, there is exophoria. This is just a small animation to show a phoric deviation. When phoric deviations are actually latent deviation, there is no manifest deviation. Both the eyes are straight, so you cover any of the eye, and then you move on to do an alternate cover test to break the fusion, so that you can manifest the phoric deviation. And then you have cover uncover test, which means that once you have covered the seemingly fixating eye, you're going to leave it, which means that that particular eye which was covered will be uncovered. And what information this test gives you is whether it is a unilateral strabismus or an alternate strabismus, which means that if the eye under cover has lost fixation and other eye has taken up the fixation, when you uncover it, if the other eye is still maintaining the fixation, then it is an alternate deviation. And then if it leaves the fixation, then it is a unilateral deviation. So, and then you have alternate cover test, mainly for breaking the fusion, mainly done for phoric deviations, mainly done for latent deviations. So this is alternate cover test should not be done in all the cases, because if you do an alternate cover test, you are going to see an alternate tropia, regardless of whatever is the deviation, whether it is phoric or tropic. So prism cover test, here you want to measure the amount of deviation. And how do you do that? You start putting prisms of progressively high power with apex towards the deviation. Now here you would put prism apex towards the deviation, but when you note it with regards to the base. So for esotropia, you write base out. For exo, you write base in, and likewise for hyper and hypo. And here we are like if the eye is on the outer side, you would put apex towards the deviation. That is how you have to remember it. But when you record it, you put base out, base in, and then there are. I mean, this is okay. So this is about fusional amplitudes. So these are, I mean, this is going to take some time. So fusional amplitudes, you measure fusional amplitudes, convergence amplitude, divergence amplitude, and convergence amplitude. You progressively take a prism bar and progressively start increasing base out prisms, and there is a point of neutralization, and then, there is a point of breaking, and then you go back, and then there is a point of recovery. So that is how, so this is how you note it. I'll just come to the notations because that is what the topic was, how do you note them. So the notations for convergence amplitudes are breaking point, a certain diopters, 40 prism diopters, and then there is a recovery point, and normal convergence amplitudes are between 25 for breaking point, and point for recovery is 20. So this is okay. Then not take this. No. So this was so for ocular movements we now note them according to the millimeter of excursion, but for routine examinations most of us are still holding with -0 to -4, where 0 means that ocular motility is full and -4 that it is not moving beyond midline. But we have started measuring excursions, so we note it in terms of millimeters, and these are normal deviations. Just one. It's okay if we don't take it because normal I have taken. Let us finish in time.
Thank you, Dr. Jaspreet. Dr. Jitendra, a very extensive topic you've covered. Dr. Pradeep Sharma, how frequently do you do sensory testing in your patients?
I think I was just trying to come to that is also a mandate. You should always do at least one sensory test, Bagolini's for knowing the suppression and near stereo testing. So of course manifest ESO there won't be, so you won't have to do stereo test. But in intermittent divergent squint, stereo test would be the diagnostic prognostic thing. So you should do a proper prism bar cover test after a proper cycloplegic refraction. That is one. Secondly, the torsion whenever required, and for the motor things, and for the sensory, Bagolini glasses for knowing the suppression and the stereo testing. So these are probably the near distance measurement for both prism bar and cover test, near distance measurement. So these are the must.
What is your take on strabismus measurements in high-powered glasses?
So whenever you have high-powered or glasses, then you would have to use correction tables in order to reach the correct deviation.